death, and so ADR is a good outcome. But specifically with this product, the question, one question is, are endoscopists going to feel that this is a valuable product because it allows them to pick up some tiny additional adenomas that may improve their ADR numerically, but clinically may not make a difference to that actual patient? Or is this some we would all want?
So I guess the kind of the third element to that then would be the cost of the product, and
yeah, absolutely.
So if it was a kind of if it's a drug product, I assume it's going to be Medicare Part D or some sort of copay for the patient. So what do you think, based on your knowledge of the data and your perception of the need, what's an acceptable cost?
Good question. I think trying to think of a corollary. So the best I can, because there are very few products that we have to. There are very few scenarios in which we're adding cost to a colonoscopy, because everything is pretty much covered now. So I think probably the best analogy would be the bowel preparation product that people drink the night before.
Okay.
And I think. And so we have generic products that cost almost nothing, and we have newer products that are easier basically to tolerate. They're not as much to drink, and they taste better. And I'm frequently asking my patients to pay for those because they have copays, and actually the newest products sometimes can have relatively high copays, as much as like $50 or even more dollars, right? So what I'm asking a patient to do is to shell out for something that's supposed to be quote unquote free, $50. I've even had some that have paid more than that for something that is really just to improve their experience with the colonoscopy. And I don't see a lot of pushback, frankly, and obviously it depends on the patient population, but I don't see a lot of pushback on that. Now, it may have to do with my own patient population being, where I am practicing is relatively high sort of socioeconomic status. But, look, this product might not ultimately be something that is going to have a high uptake across all socioeconomic groups if there's a cost to the patient. But the question is, amongst the patients who may pay for a product, is this something that they might? I think they would, depending obviously on the price. But if it's an analogous situation, similar kind of copay, and I told the patient, look, this is just a couple pills to take. By the way, how many pills is it?
It looks like it'll be either 3 or 4 over a 4-hour period.
Okay. So
that's just based on the trial.
Got it. So, so at the end of the day, it's just a few pills. Presumably, that's really nothing in terms of convenience to the patient. But if I tell a patient, look, you're coming for this routine procedure, and we have a way to improve our ability to detect polyps, even if it's a modest improvement, patients are very, I think, interested in they're very motivated to have their colonoscopy be as effective as possible for cancer prevention. So if it means shelling out a little more to take something that's not too difficult to take, I would expect that my patients would probably have no problem with it.
And I guess so if I can characterize your feelings about it and tell me if I'm wrong, that I guess from the specialists in the area that the unmet need is relatively small and the data isn't as mind-blowing as you might hope, but given patients only have a colonoscopy once every 10 years, it's a relatively small cost, they're relatively motivated, that you could have a lot of patient-driven usage of the product. Is that a fair assumption?
Yeah, I think that is a fair assumption. I think that in the especially among patients who are more knowledgeable, um, you know, these days are kind of doing their own Google research before they come to the doctor.
So it wouldn't even be a case of you suggesting this is available.
Some people would probably ask for it if it became something that was sort of out there in the that the product was it would have to do with marketing and whatnot. But if the product was established out there and found out about it before coming in, but I mean certainly my patients probably would. So I think even ask for it. We've seen that to some extent with some other improvements in screening colonoscopy. So we at my center use a scope called the Fuse scope, which has 3 lenses on
Okay.
in the colon, and that's something that patients actually found out about and started to ask for. Not that many patients, but some of it even could be patient-driven. But I think it would mostly probably have to be driven by the docs, because ultimately I don't think patients or average patient is really like that knowledgeable to the point at which they're like, I want you to do everything possible to increase adenoma detection. Yeah. That's probably a level to which the average patient is not.
So somebody suggested, and I don't know, so that a lot when we do a lot of these feedback calls, you get different kind of characteristics amongst different types of doctors, and some are willing to try the next best drug, and some you have very high clinical inertia. How would you describe colonoscopists about would
I think that we're very used to advances in technology, because there are many that occur in our field, and with devices, with new imaging things, beyond colonoscopy, even things like capsule endoscopy. And by and large, I think because we're a very procedural-based specialty and we deal with a lot of equipment and technology in general. I mean, the technology for this drug is based on a drug that's used for ulcerative colitis called Lialda, which we're all pretty much familiar with. So we kind of understand what this is. It's not a new concept to us. Multiple drugs actually that use this technology primarily for inflammatory bowel disease, which the average gastroenterologist that's doing screening colonoscopy is probably taking care of patients with inflammatory bowel disease and actually knows about MMX and actually has been using it in their patients for a long time. So you're not actually even talking about something that's that new or crazy.
Yeah.
We all have used many of us have used methylene blue already. So you're not talking about something. I don't think there'd be that much inertia, certainly for me. And another thing I'll just point out to you, which is from my perspective, and this is just my perspective, but I would welcome the opportunity to offer a patient something that could that other gastroenterologists might not be offering, that I can reliably say, may have a clinical benefit to them, even if the benefit is small, and gives me something to talk about with them at their pre-colonoscopy visit, which is usually like a pretty boring visit. And hey, look, there's this new product. Enable you to enable me to have a better look at your colon, just to take a couple tablets. Usually with copays with commercial insurances in this country, especially when the drugs first come out, there's a copay cards and things like that sometimes make it only like $20, so it's sort of like a nominal cost, basically.
Yeah.
So I think I would like to have that option for patients. As long as there's no downside to it, which I think most people would accept methylene blue is pretty safe.
Yeah.
I haven't hesitated to use it in other patients. So in that regard, I think the level of inertia would be low.